Dr. Anusha. Good evening, Dr. Anusha. Dr. Anusha, are you able to hear us? Dr. Anusha.
Good evening, sir.
Good
Am I
evening, Dr.
audible, sir?
Anusha. Can you, you're good and audible. Can you switch on your PowerPoint? Good evening, friends. We warmly welcome for this edition of the PG Clinic. We have very eminent faculty and very important cases for the discussion. The first case will be a carcinoma thyroid to be presented by Dr. C.S. Anusha from Al-Amin Medical College, Bijapur, kindly contributed by Professor Nishikant Puja sir. The second one will be by Dr. Arya Singh from Institute of Medical Sciences, BHU Varanasi, permitted by Professor Rahul Khanna sir. He'll be a case of epigastric mass. We have Madam Pooja Ramakant ma'am, HOD Endocrine Surgery at KGMU, Professor A. Prabhakar, HOD Surgery from Chettinad Medical College. We expect Dr. Anand sir and I think Dr. Johnson is already here. They'll be conducting the epigastric mass case. And we have Professor Sri Harsha, he is a professor of surgery at Sri Madhusudan Institute of Medical Sciences, Bengaluru. So without much ado, we'll start the presentation. Dr. Anusha, please make this into full screen and go to the first slide. Good luck to you, faculty. Please take over. We have our own eminent faculty. We have Professor T. Srinivasan, Professor Jailal joining us. Good luck to you, doctor.
1 second, sir.
Please start your presentation.
My is visible, sir?
Yeah, yours is good.
Okay.
Good luck.
Okay, thank you, sir. Good evening, everyone. Myself, Dr. Anusha CS, third year postgraduate, Al-Amin Medical College. And I am doing this presentation under the guidance of Dr. Nishikant Puja, Principal and Professor of Surgery, Al-Amin Medical College. So, is my video available, sir?
You are good, ma. You are good to go. Please go on.
Oh, okay, sir. So here is a patient by name Kashimbi, age 70 years old, 70-year-old female, hailing from Kalaburgi. Occupation, she is housewife by occupation. She comes with the chief complaints of.
Please share your screen.
Huh, sir?
Sir, her screen is visible, Dr. Harsha.
Yes, sir.
Please go ahead, ma. Please go ahead.
Okay, she comes with chief complaints of swelling in front of neck since 30 years and complaints of difficulty in swallowing since 6 months and difficulty in breathing since 3 months. History of presenting illness, she was apparently all right 30 years ago when she noticed a swelling in front of neck, which was insidious in onset, which was initially of size approximately 2x2, and which was in the midline and more towards the right side. It gradually progressed to attain the present size over 30 years with no, the swelling has no accompanying pain or fever. No history of regression in size, no history of rapid increase in size, no history of appearance of new swelling elsewhere in the neck, no history suggestive of lymph node swelling. There is no history of discharge from any discharging sinus. There is no history of evening rise of temperature, no history of loss of weight, cough, expectoration, hemoptysis, or no history of any contact with the case of TB. No history of swelling anywhere else in the body, bone pains or bleeding gums. No history of swelling in oral cavity, dysphagia, dyspnea, or change in voice. She also complains of difficulty in swallowing for solids. She complains of difficulty in breathing on lying down since 3 months, which gets relieved on sitting upright position. No history of syncopal attacks. No history of recent weight loss. No history of bone pains, swelling in scalp or in lateral part of neck. No history of irradiation to neck in childhood. No history of suggestive of thyrotoxicosis. That is, no history of chest pain, palpitation, or exertional dyspnea. Patient has not noticed any enlargement of eyeballs. No history of tremors, excitability, excessive sweating, diarrhea, or menstrual disturbances. She has history of sleep disturbances, and there is no history of hypothyroidism, no history of cold intolerance, constipation, mental lethargy, edema of feet and face with hoarseness of voice. Past history, she's a known case of hypertension, was on medication. She no history of any intake of anti-thyroid drugs or anti-TB treatment. No history of irradiation to neck. No history of previous medical or surgical treatment for the swelling. Personal history, she has mixed diet, appetite is reduced, sleep is disturbed, bowel and bladder habits are normal and regular. No history of any habits. Menopause, she had achieved menopause 30 years ago. No history of similar swelling in the family. So summary, there is a 70-year-old housewife presenting with swelling in front of neck that has been present for the past 30 years, which is gradually increasing size, moves with the deglutition, no features of hypo or hyperthyroidism, and has associated features of compression.
Dr. Anusha, go back to the first slide.
Sir, first slide.
Yes.
Yes, sir.
Swelling in front of the neck since 30 years. Difficulty in swallowing since
Sorry,
6 months. Difficulty in breathing since 3 months. What could be the reason for the difficulty in swallowing?
Sure, the
When
large
patient,
swelling which is
yes.
It's a very huge swelling, sir, which is compressing on trachea and esophagus.
Okay. Anisha, what is the difference between dysphagia and difficulty in swallowing?
Dysphagia is difficulty in swallowing, sir.
But in the history you are said there is no history of dysphagia. But here you are saying there is a difficulty in swallowing. There is a lot of contradictory statements in your statement. You said no history of thyroid toxicosis, but you are saying there is a sleep disturbances. You are saying the patient attained menopause 30 years back. That means at the age of 40, she has attained menopause. So is it not a significant one? And you are apparently writing a lot of things which are not related to that. But however, you are making a very bold statement. There is no history of thyroid toxicosis. Immediately you are going. No history of dysphagia, but you are describing on the swallowing difficulty. So how the swallowing difficulty happens in a thyroid? Is it compressing the esophagus directly? What is the relation of esophagus and thyroid gland?
It is posterior, sir.
It is not directly posterior.
It is trachea is present behind that, sir, and behind that there is a.
Can somebody press the trachea and the esophagus simultaneously? What will be the first symptoms? You will have only choking and difficulty in breathing. It will not be the difficulty in swallowing. When your trachea is compressed, nobody will attempt to swallowing.
Okay, sir.
What is the relationship? Where the esophagus starts? Or which phase of the swallowing is affected? What are the phases of swallowing?
The initial phase, sir, esophageal.
What are the phases? There is 3 phases, ma. There's oral phase, cervical phase, and esophageal phase. Which phase of the swallowing is affected here?
Okay, sir.
No, I'm asking. So be careful in putting these words. And if you say there is difficulty in swallowing, you must explain what kind of difficulty. And you are even to this extent, you are saying there is a difficulty in your solid food. See, this inconsistency should not be there in your case. And what is the cause for difficulty in breathing?
It's a long-standing goiter, a multinodular goiter, which has a compressing trachea, sir. So
compressing trachea will not cause a difficulty in breathing. Huh? You have said already when the patient is not able to lie down.
When she lies down, the swelling is compressed. On sitting position, It is not, sir.
Why?
The swelling will lie on the trachea when on lying down position.
Even
sir.
otherwise, it will lie on the trachea. It is not separated from trachea. See, these are significant findings because you are including these things. That is a typical feature when you are thinking and retrosternal goiter. or that is coming out. So when the pet is normally now compression and lying down under compression is not going to happen. So what I could understand, you are putting your theoretical knowledge into the clinical presentation, which will not suit you. Go ahead, go ahead. Next slide, go ahead.
What do you mean by positional dyspnea, Anisha? Dr. Anisha.
Positional dyspnea, it's when she lies down, she'll have more dyspnea, sir.
Why, when the patient lies down, she is having dyspnea? Why not in the upright position? What could be the reason for that?
Diaphragm
Otherwise,
expansion,
what are
sir.
the causes of orthopnea?
The diaphragm expansion, sir. When on sitting position, it can expand more and the inspiratory capacity will be increased.
So you will sleep on sitting position than on lying down. Normal individual will sleep on a lying down position, no?
Lying down position.
And your theology, your theory that during lying down, diaphragm do not move, should be true for everybody, no?
In case of congestion, sir, there is more when on lying down position, there is no more venous return, which will reduce the inspiratory.
That is true. That is a congestive cardiac failure. Congestive cardiac failure, you are right. So you mean to say this patient has congestive cardiac failure?
No, sir.
No. And what do you mean regression in size?
Regression in size, sir. Swelling which reduces in size, sir. If any
can we cite one example on how the thyroid swelling will regress in size?
Any hemorrhage into a degenerating nodule will regress in size, sir, and eventually it becomes disappears.
Hemorrhage into the nodule will regress size.
Degenerating cystic nodules.
It will not regress, it will increase in size. Only possibly if you are thinking it's an abscess and if you are treating it antibiotic. But in a 70-year-old individual, thyroid abscess is not common. Why? Acute thyroid abscess is not a common entity in a thyroid condition. What is the reason? Thyroid has a thick capsule, thyroid has a rich blood supply, thyroid has a rich lymphatic drainage, thyroid has iodine as a content. So abscess cannot happen. So every word we are writing in your case sheet, you must be able to explain. Yes. What is the difference between rapid increase and sudden increase?
Sudden increase is when for the duration, sir. Rapid increase.
What is the reason I'm asking? We know the difference of sudden and
rapid increase.
In which condition you are expecting a rapid increase?
In case of malignancies or aggressive malignancies like anaplastic carcinomas, and in case of hemorrhage into a nodule. So in case of benign swelling which has turned recently malignant, which will have rapid increases.
A swelling which is increasing in size for 30 years, you are expecting sudden anaplastic change.
No,
okay,
sir.
Okay. Prabhakar sir, you can ask.
Yes, sir. What is the difference, ma'am, between rapid increase and sudden increase? Sir has asked. Rapid increase means in months together. Sudden increase means it is due to some degeneration, due to some hemorrhage or rupture of some blood vessels into that cyst. That's why that is called sudden increase. This one is rapid increase. In your case, there is no rapid increase or sudden increase. Yes, okay. Then no issue of appearance of new swelling cells were in there. No issue suggestion of lymph node swelling. No history suggestion of lymph node swelling. What do you mean by that?
To rule out if it is a lymph node swelling, sir, certain history.
How did you ask that history to the patient?
Patient will tell.
Yes, sir. Sorry, sir.
How did you ask the question to the patient? Patient can differentiate a lymph node and a swelling?
No, sir. I'll ask the history, sir. If there is a evening rise of temperature.
History only you are saying there is no lymph node swelling. How much categorically you are saying? And you are putting as a postgraduate, coming and presenting for a thyroid, tuberculous sinus, tuberculous evening rise of temperature, that is not expected of you. We don't going to get a swelling which is progressing for 30 years in the thyroid region, which is going to be a tuberculosis in origin. So you must be able to correlate how you are presenting the case, not just bring all that what you know. So you are now trying to explain the sinus and the swelling, evening rise at temperature, loss of weight. Already you have said there is a weight loss, appetite is poor. In one
When
part
you-
you have said your appetite is poor.
Yes, sir. She has a poor appetite, sir.
Okay, but you are not mentioning that is also a feature of tuberculosis then. So it is not necessary. What I want to say, these all are not necessary. Don't bring to your theory knowledge here and say that it's sinus and other thing. You thought of thyroglossal cyst. That is a different thing. But here you are mentioning only about a tuberculosis. Kindly avoid these statements. Okay.
Okay, sir.
Why you have elicited the issue of swelling in the oral cavity? In what way it is related to a swelling in front of the neck? Dr. Anusha.
Sir, a midline swelling which can include Ludwig's angina, which can cause cellulitis. It is also a midline swelling.
Ludwig's angina is not a midline swelling. What do you mean Ludwig's angina? And that is an acute
It's a
condition. That
cellulitis.
is not the condition you are going to
Acute.
talk in a 30 years history.
Yes, sir.
And that is not going to be seen in the oral cavity. Ma?
And the floor of the mouth and sir.
Which
What
cannot
is
be seen in the
lingual
oral
thyroid?
cavity.
What is lingual thyroid, Dr. Anusha? And where it will be commonly present?
Near the cecum, sir, posterior tongue, posterior part of tongue.
Cecum is inside the abdomen.
For
What do you mean by cecum?
Sorry, sir. Near the posterior part of the this posterior part of tongue, sir, it will be present. Lingual, where the thyroid usually arises at the embryonic stage.
Okay, why you have asked the issue of change in voice when the patient presents with the swelling in front of the neck?
If the swelling is affecting or compressing or encroaching the recurrent laryngeal nerve to see that voice change, sir. Hoarseness of voice if she has.
That recurrent laryngeal nerve supplies what muscles?
Yeah.
It supplies all the muscles of vocal cord except cricothyroid, sir, which is supplied by external
All
laryngeal
the intrinsic muscles of the
intrinsic muscles.
larynx, except
cricothyroid, sir.
And that cricothyroid is supplied by which nerve?
External laryngeal nerves.
External branch of the superior laryngeal. Okay. The only one muscle which is present outside the larynx, but it is called as an intrinsic muscle. What is that muscle? Now only you told.
Cricothyroid only, sir, from cricoid cartilage.
Yes, cricothyroid. Yes, good.
What are the voice changes you are expecting?
Hoarseness of voice, sir,
What do you mean by hoarseness of voice?
The pitch is lost, sir.
Pitch is lost.
Pitch is lost in hoarseness of voice.
You will ask what is pitch?
Then what is huskiness of voice? What is the difference between huskiness and hoarseness? Is there any difference or both are same? Dr. Anusha.
Huskiness is
which nerve is called a singer's nerve?
External laryngeal nerve, sir.
External branch of the superior laryngeal nerve is called as a singer's nerve. Why it is called as a singer's nerve?
Because of the loss of pitch, if it is affected, sir, the patient is not able to reach the high pitch which is required for the singers.
Yes. High pitch will be lost. Then what is hoarseness of voice? Which nerve is injured in hoarseness of voice?
Recurrent laryngeal nerve, sir. It will be a rough voice, sir.
Why? How
Okay.
it produces rough voice? Ma? Why it produces rough noise?
It's because of the weak breathing and paralysis of the vocal cord muscles, sir.
Vocal cord. So vocal cord paralysis is the cause.
Uh,
Unilateral vocal cord palsy will produce hoarseness of voice. Okay. Yes.
Okay. What is hot potato voice?
Hot potato voice is seen in quinces or peritonsillar
No, we are talking with the
abscess.
thyroid. We are, don't go outside that. Huh? You already said that answer once.
Muffled voice, sir.
No, hot potato is something you are having in the oral cavity, and then your voice will be like hot potato voice. Suppose when you have a lingual thyroid.
Lingual thyroid, huh, sir.
So how will you manage lingual thyroid? Suppose you have a case of a lingual thyroid.
Will you do excision of that lingual thyroid, or will you give any drugs? Before that, will you do any investigations?
Sir has made the question very simple. Choice is given to you. So surgery is not the option. Huh? You must. Okay. And
Non-recurrent recurrent now is common in which side, Dr. Anusha? Right side or left side? Non-recurrent recurrent laryngeal now. It's very common on the right side or on the left side, and why? Huh? Left is
left
the
side, sir.
no. Right side is the common non-recurrent recurrent laryngeal now. Okay. Right, okay, due to the congenital anomalies of the subclavian artery. Right recurrent laryngeal now records on the subclavian artery. Left recurrent laryngeal now records on the
aortic.
Aortic arch. Okay, right, good.
So the patient is menopause 40 years back, no? 30 years back. But you are asking the after 30 years, right now the swelling is there. The swelling started after the menopause only, because the swelling period is only 30 years. Patient attained menopause after 30 years. Then how do you ask the history of menstrual disturbance to establish your thyrotoxicosis? It's a routine. All questions must be relevant to the patient. And how will you ask the history of tremor? What kind of tremor you get?
Fine tremors, sir.
What do you mean by fine tremor?
It's intention, sir. When you are trying to do any work, we'll have it.
Not when you do a work. That is the exercise-induced tremor. That is not the fine tremor. When you go for exam, when somebody is asking the question, your hands will start shivering. It's a low
adrenergic overactivity, sir. Sympathetic.
Okay. Which is not many times identifiable. Patient will not come out with. Even to the examine that, you have to do a small paper to do that. So most of the time, the fine tremor will not be elicited in the history. So you have said now, no thyrotoxicosis. Next slide, next page. There is a history of sleep disturbances. Sleep disturbance, is it a feature of thyrotoxicosis?
Yes, sir. But here she's having sleep disturbance because of the orthopnea, so difficulty in
that is what in the examination, never come to a conclusion. Whatever the positive feature present, you just present. Don't try to explain that all the other thing, excitability, then why he is not sleeping. Probably he has an anxiety. Probably he has some other conditions. But so you can only also say no history of thyrotoxicosis. History suggestive of thyrotoxicosis is not apparently present. Then it would be better, not going on. And again, you are going for a hyperthyroidism, hypothyroidism, now euthyroidism, all the features you are going to enumerate. How did you ask the history of cold intolerance?
Cold intolerance, how she cold intolerance.
So here also there is a hoarseness of voice. Thyrotoxicosis, your recurrent laryngeal nerve also produces hoarseness of voice. What is the difference? Hypothyroidism also produce hoarseness of voice. Malignancy also produce hoarseness of voice. What is the cause for hoarseness of voice here?
Laryngeal edema, sir, in hypothyroidism. In case of
hypothyroidism,
hypothyroidism.
Okay.
Hypothyroidism will be edema.
Go to the previous slide, Anusha. Go to the previous slide. Diarrhea. What are the two conditions of thyroid lesions in which you will get diarrhea?
In case of hyperthyroid.
Yes, one is hyperthyroidism or toxic thyroid. Number two.
One is a medullary carcinoma, sir. Secretory diarrhea.
Why in medullary carcinoma the patient is having diarrhea? What is the concept behind that? What is the reason for that?
It secretes 5-HT, sir, serotonin, and there is it acts similar to carcinoid syndromes, 5-HT, ACTH, prostaglandin secretion. Maybe that is the reason.
Okay. Why you ask the history of irradiation to the neck in childhood? In what way it is related to the swelling in front of the neck?
I didn't get you, sir. Sorry, sir.
Irradiation to the neck in childhood, you have elicited the history. Why?
Because any previous irradiation may lead to papillary carcinoma, sir.
How much time interval it will take?
Around 5 to 10 years, sir.
But your patient is 70 years.
Yes.
Why in thyrotoxicosis you get diarrhea?
Increased ganglionic stimulation, sir, ganglionic cells.
Sympathetic overactivity. Which ganglion?
Sympathetic.
Why you ask the syncopal attacks?
Any meds to the skull and brain, so that is why syncopal attack, or any other
meds to the skull will produce syncopal attack.
And this swelling encroaching the carotid artery, if it is there, then
bilateral compression of the carotid artery.
Carotid artery.
Difficulty in swallowing for solids. What do you mean by that? What are the conditions in which the patient will have difficulty in swallowing for solids? What do you mean by achalasia cardia?
Lower sphincter tone will be increased, sir. She'll have regurgitation. There will be beak appearance.
No, what will be the complaint? What will be the complaint?
Regurgitation, sir.
No, it's not the regurgitation.
Swallowing difficulty.
Which swallowing?
For solids.
Solids or liquids?
Both, sir. Solids and liquids.
No, there is obvious difference between carcinoma of esophagus and achalasia cardia.
Yes.
When you say solid, it's two conditions. You have only achalasia cardia, carcinoma. In a carcinoma, you get a solid. Okay. In achalasia, you will have a liquid will go. Or liquid will not go. The solid will go. Patient will have a difficulty because the spasm is there.
Yes. Go to the next slide.
Go back. Go. Next slide. Okay.
Next slide.
You have asked before that. You have asked for the metastatic features also, because 70-year-old individual, long-standing.
Yes, a loss of weight she has. Other than that, irradiation history I have asked. And
radiation, all this is a 70-year-old individual. We don't go into that. That is our papillary carcinoma. We don't expect a papillary carcinoma in a 70-year-old individual. So you are going to have a long-standing thyroid turning into either a lymphoma or follicular carcinoma commonly. So that can produce a bone metastasis, which will produce a pain or anything else. What kind of secondaries you will get in a follicular carcinoma?
What are the typical characteristic features of metastasis in the skull of follicular carcinoma?
It will be cystic swelling, sir, which is warm, and vascular pulsations will be present, sir.
Is it a vascular pulsation?
Now, pulsations will be present in
Pulsation
the
of what?
pulse. Usually, the first thing, the swelling is vascular. Second thing, that it would have eroded the skull tables, sir, inner and outer tables, and may also transmit pulsations
Very
from the
good. So
brain.
there is no skull there. No, that is the skull will go when both the pole, outer and inner pole are destroyed. You'll have the brain parenchymal, the meninges and the coverings. That pulsation you will be able to appreciate. That is why it is very, very dangerous. You should not go and touch on that. What other condition you get pulsatile secondaries? Osteolytic secondaries. Anything, any tumor from the abdomen? Renal cell carcinoma.
Yes, renal cell carcinoma.
Okay. So you must not talk about pain here. So each malignancy, when you are talking about a secondary feature, there is some characteristic pain. Pain is not a characteristic feature because it is not going to go into the lumbar spine or producing a. So unless you make that specific to your case, specific to your examination, then it will be of use. Okay, go ahead. Appetite reduced, sleep disturbed. Okay.
What is the normal iodine requirement for a human body? Daily requirement.
0.1 mg per day.
100 to 125 micrograms per day.
Microgram,
Which
0.1
normal
mg.
natural diet is rich in iodine? Which natural diet?
Fish, sir, and iodine, and
non-fish,
milk,
fish,
milk.
or sea fish?
Sir?
Sea fish. Sea fish.
Seafood. Seafood.
Seafood. Seafood. Okay, right. Okay, next slide.
Shall I go to examination, sir?
If the swelling is in the neck or in front of the neck?
In front of neck, sir.
It is in front of the neck means not in the neck. Something is so never use that word in front of the neck. Swelling is in the anterior aspect of the neck. Or you can say thyroid region of the neck when you are explaining that. Not say in front, behind. These are not the anatomical terms. Nowhere you will read front, back in anatomy. Anterior, posterior, that language you must use. In a summary. Okay, go ahead.
So are you suspecting benign or a malignant lesion after eliciting the history?
Benign lesion, sir.
Why? Why do you suspect benign? Why can't it be a malignant swelling from the thyroid region? Because it is present for the past 40 years, isn't it?
Yes, sir.
What are the points against malignancy? In the history.
Against malignancy, there is no similar swelling. Otherwise, lateral neck swellings. There is no lymph nodes spread. Then there is no. Sir?
No change of voice, isn't it? Hoarseness.
No change of voice.
Right. Okay, right. Go ahead. General examination.
General physical examination. Here is 70-year-old female, moderately built and nourished, well-oriented, type-placent person. Vitals, her vitals was stable. BP 130/70, pulse rate 76, and respiratory 20 cycles per minute. She had no pallor, icterus, cyanosis, clubbing edema, and lymphadenopathy. No eye signs and no tremors. Local examination. Patient was examined in a sitting position in a well-lit room after taking an informed consent, and with the proper exposure of neck until mid-chest. Look, inspection, swelling present in front of, in the neck, in the anterior region of neck and to the sides. Swelling measures approximately 20 cross 10 centimeter. Swelling extends from thyroid cartilage superiorly to suprasternal notch inferiorly and laterally up to sternocleidomastoid muscle on both sides. It has bossylated surface and well-defined margin. The overlying skin is normal with no visible scars or sinuses. Swelling moves up with deglutition and not with protrusion of tongue. There is visible pulsation seen on the swelling. Prominent neck vein seen on the swelling. This is a short clip showing the movement with deglutition. On palpation, there is no local rise of temperature, no tenderness. All inspectory findings were confirmed. A swelling of size 20 cross 10 centimeter present over the anterior aspect of neck and which has well-defined borders. On the right side, the swelling extends from 2 centimeter below the angle of mandible, right mandible till the level of clavicle. And on the left side, the swelling extends 5 centimeter below the angle of mandible to 2 centimeter above the left clavicle. It has variable consistency. Surface of the swelling is bossylated with multiple nodules of varying size, and the largest nodule measures about 9 cross 8 centimeter. Skin over the swelling is pinchable. Swelling is mobile in both planes. Trachea is pushed to left side. Carotid palpations are palpable on both sides, but is displaced laterally. No palpable cervical lymph nodes. On auscultation, there is no bruit heard over the swelling. Systemic examination, respiratory cardiovascular, central and upper abdominal examinations were normal. Summary, a 70-year-old female presented with painless progressive swelling in front of neck since 30 years with symptoms of compression with no eye signs and symptoms of hypo or hyperthyroidism and no lymphadenopathy. Swelling moves with deglutition with bossylated surface and variable cystic to firm consistency. It has no features of fixity to nearby structures. Bilateral carotid pulsations push to lateral side and trachea push to left. Provisional diagnosis. Non-toxic multinodular goiter.
But in the presentation, you never presented like a multinodular goiter. You said the single swelling that is progressively enlarged. Then how many swelling you have now? Can you go to the picture?
It has multiple swellings, sir. I have
You,
mentioned
in the
in the
history, you have never. In the history, you said this is a single swelling. No other swelling is present. Can you show the picture? And this is not the description of such a large tumor. On either side, there is even there is a two. Even the left side, you have to see another swelling. And according to you, the first swelling started at the right side. So how deeply it has progressed, the tense. So that's a literal expression of that swelling. By in the history, we could get the picture of your presenting. What you said, it is a slow swelling, it is slowly increase and attain the present size. That's all. Even not even mention the size in the history size. So you should start a small swelling. Now there is, it looks like a nodular, multiple nodular swelling. That you can, in the history itself, you will be able to, the patient can easily tell you which swelling started first, which swelling is coming late. Okay, go ahead, go for the examination. Start describing examination. Now go to the examination.
Sir?
Go ahead with the local examination. You must also write examination of the thyroid region, not local examination. Okay. So
what are the
examination of
borders
thyroid
of thyroid region? What are the borders of thyroid region? Anusha.
Sir?
What do you mean by thyroid region?
Borders.
Borders
boundaries
of
thyroid region. Boundaries of thyroid region.
Boundaries.
So boundaries, a normal thyroid gland extends from the thyroid cartilage, sir, up until 6th tracheal ring.
What is the size of the thyroid cartilage?
Thyroid cartilage, it is around 20 gram. It measures, sir. No, so sorry, sir. Thyroid gland cartilage.
Size. Thyroid cartilage. What is the size of the thyroid cartilage? It is more than 2.5 centimeter size. So when you say upper border is thyroid cartilage, what do you mean by? Is it the upper border of the thyroid cartilage or lower border of the
No,
thyroid cartilage?
middle, sir, from the middle of thyroid cartilage.
What is that line called?
Oblique line on the thyroid cartilage, sir.
Why that is an upper region? Why the thyroid will not go above that? Because all the muscles are attached at that region.
Are attached to the
Muscles are-
oblique
so,
lines.
so you must be able to very clearly say the upper border or the oblique line of thyroid cartilage. What is the lower border?
C6, sir, until.
That is posterior, ma. You can't see that. When you see the
Okay,
boundaries, you are talking from the anterior part.
for up until sixth tracheal ring, sir. Sorry.
Sixth tracheal
Suprasternal
ring.
notch of Burns. Then lateral aspect, anterior border of the sternocleidomastoid muscle.
Sternocleidomastoid.
Okay. What is the difference between basilated surface and nodular surface? You are told that in your case it has basilated surface. Is there any difference or both are same?
Basilated is nodules with bigger size or bumpy surfaces. Nodular surface when it has grooving and elevation are very
Yes, more than 2 centimeter
close.
in diameter, that is called basilated surface. Less than 2 centimeter nodular surface. Okay.
Nodules.
Peak and
In
pit must
which
be there.
condition you will get visible pulsations over the thyroid?
Visible pulsation.
In your case, visible pulsations is seen, you are told, isn't it?
Yes, sir.
How it is
What
possible?
does it indicate?
Where it is seen? And prominent neck veins. In which condition of the thyroid you will get prominent neck veins? What is Pemberton sign?
Pemberton sign is to see retrosternal goiter, sir. When there is patient is asked to raise his hands touching the ears, both his hands, and patient is allowed to wait in that position for a while. And there is congestion of the face and dilated veins in the neck and chest regions.
Why?
Because of the retrosternal goiter, there is thoracic inlet block. It's blocking the thoracic inlet, so that is why there is
Even otherwise, you have a thoracic inlet. When we are lying down, also you have a thoracic inlet. Standing, also you have thoracic inlet.
What will
Thoracic
happen?
inlet
It
is
will,
always there, no?
Nice, sir. It will the retrosternal goiter will cause block the veins in the thoracic inlet, causing congestion.
Veins in the thoracic inlet. What is
Causes,
nutcracker effect? What is corkscrew effect?
Nut, when there is a tracheal this things are tugs are due to aortic aneurysm.
No. Don't go beyond that. We are only talking still within that thyroid. So there's two schools of thought. One is a corkscrew effect. That is like a soda bottle. The thyroid moves up and block that area. The inlet area is closed. Second one is a nutcracker effect. Like surroundingly, it is compressing. It is actually the surrounding compression is taking place, not it is going up and blocking it. So nutcracker effect is an unexpected phenomena for the Pemberton sign. So your patient, for the history and the presentation is obviously there is a lot of difference. Sir has asked you a question, the pulsation, when you will see? Commonly we see in thyrotoxicosis. And distant and neck veins, commonly we see retrosternal goiter. But your patient has both. Okay, go ahead.
Yes. Next slide.
No, is it the swelling extends only up to the external suprasternal sternocleidomastoid?
Yes,
So
sir.
the
Sternocleidomastoid is the.
Show the picture.
sir?
Show the picture. That right side swelling is far away from the sternocleidomastoid.
Yes.
Is it go behind the sternocleidomastoid or above the sternocleidomastoid?
Usually, it is thyroid swellings will be behind the sternocleidomastoid, sir.
So in your case,
The same, sir. It is deep to sternocleidomastoid.
why? Why you are very confidently saying it will be only deep to sternocleidomastoid? You are right in saying that. But what is
But you
the
have never
reason?
mentioned in your presentation, ma'am, in relation to sternocleidomastoid, what is the plane of the swelling? Have you mentioned? No. Yeah. Now, sir is asking. Yes, tell.
If you see this only, the second, the left only, it is looks like it is anterior to sternocleidomastoid.
Yes, left side.
Yes, sir.
And right side also.
No. Okay, little more description of the case pertaining to the case is needed. Okay, Anisha, go
Yes.
ahead. Go ahead.
Yes.
Go ahead.
The lower border, are you able to feel?
Yes, sir.
And why you have not
On
mentioned?
Again, go to the picture. There is a swelling in the left side, lower border. I don't think you will be able to see there's a swelling here also. What is that swelling?
Which one, sir?
It comes here, no? There is at the level of clavicle, there is a prominent structure is seen.
One is from the right lobe, another one is from the left lobe, and another one is from the isthmus. Like that?
Is it a trail sign?
Yes, sir. Prominence of sternocleidomastoid, sir, at the site of because the
What is
trachea
that
is
sign?
deviated to the left, sir. Trail sign is an inspiratory sign, sir. Where a sternocleidomastoid muscle becomes prominent in the side where the trachea moves, sir.
Some prominent vein is also seen on the left side of the neck. Yes, what you are showing. What is that vein?
But where is the clavicle you show me? In the picture, you see the cursor, you saw where is the clavicle?
Here, sir.
Clavicle, ma.
Clavicle.
Yes, right side.
Right. This second picture. Ma.
It's somewhere.
So is the swelling is below the clavicle or above the clavicle?
Above the clavicle, sir.
Where is the clavicle then? There is the clavicle. So low.
This one, sir.
That swelling, is it above the clavicle or below the clavicle? I'm asking.
Above the clavicle, sir. This is
It
the
cannot be. No, the clavicle.
parts.
Clavicle is above. Where the cursor is there. So what we are seeing that bud is not at the clavicle, below the clavicle. This, if you have a sternocleidomastoid muscle, should be above that sternum. Yeah. Okay, anyhow, we are not physically seeing the case, but you must be able to very carefully, because when you are presenting the case in the examination, so each point you should explain. Okay, go ahead.
In your case, carotid pulse is displaced.
Pulses. It is displaced bit posteriorly, sir, in the right side, more in the right side.
What is Berry sign?
Berry sign where the carotid pulsation is not felt because the enroachment to the carotid sheath, sir, in case of a carcinoma.
Okay, where did you?
In case of anaplastic, sir?
Why carotid sheath? If the carotid sheath is infiltrated, why you are not feeling the pulse?
It will infiltrate the carotid artery which is present in the sheath.
So the answer should be it's infiltration into the carotid tunica muscularis is affected. So the contraction and relaxation of the carotid is not just like a vein. The blood will flow. You can't feel the pulse because there is no muscle. Similarly, here this blood flow is not affected, but the pulse is not generated because the carotid artery musculatures are infiltrated, not just because the carotid sheath is involved. Okay.
When you are palpating the carotid artery, which artery you are palpating? Internal carotid or external carotid?
Internal carotids.
Sarah is putting you in a trap when asking the two choices. Both are wrong answer.
Common carotid is the correct. Okay.
So the right answer is common carotid artery, not the internal. Internal carotid artery you can palpate in the neck?
No, sir.
So where do you feel the internal carotid artery?
In the tonsils, sir, inside the
Very
cavity.
good. Go ahead.
Where will you palpate the common carotid artery in the neck, Anisha?
In the upper part of sternocleidomastoid, anterior part of sternocleidomastoid, sir.
Per pot.
Okay.
Where it bifurcates?
In the upper level of thyroid cartilage, sir.
No.
Upper corner of thyroid cartilage.
Thyroid cartilage is quite a large one. What is C6 vertebra corresponds to? You said previously, you said the C6 carotid tubercle. It corresponds to what cartilage?
Against that bone, transverse process of the sixth
C6.
cervical vertebra, Crescent tubercle. Okay.
That
Against that
corresponds
tubercle.
to what cartilage?
First tracheal cartilage, sir.
No. Just you are a little lower. Above that. It
Cricoid
corresponds-
cartilage, sir. C6
cricoid
corresponds to
cartilage.
cricoid cartilage.
What are the anatomical significance at the level of C6 happening? So that is a very important landmark where the trachea becomes, larynx becomes trachea, pharynx becomes esophagus, all that level. So above that, you are going to, the artery will bifurcate into external and internal. So at that level, where you will be able to feel is the curve. It is not at the upper end, it is the lower, middle of the sternocleidomastoid.
Middle.
Okay. Go ahead.
Where will you have this grooving? In the superior
Upper pole of thyroid, sir.
pole or inferior pole? Upper pole, superior pole. Why not
Superior
in the
pole.
inferior? Why? What are the reasons for that?
In the superior pole, the artery enters more superficially, sir, and the artery and the vein are present close together, and it enters more superficially, sir. Whereas in the inferior artery enters is present bit deep to the gland, sir, to palpate.
What is the artery in the inferior pole?
Sir?
What is the artery in the inferior pole?
Inferior thyroid artery, sir.
Is it? Inferior thyroid artery is in the inferior pole?
It enters from the posterior side, sir.
In the middle part of the thyroid, not
Middle
at the.
part.
So there is no artery in the inferior pole. Only inferior thyroid vein is there. No? So this.
Okay, sir.
So your case is not a thyrotoxicosis, but you have dilated veins. Can it be due to any obstruction?
No, sir, no signs of venous obstruction.
Suppose you are expecting a carotid stenosis or carotid block. Where will be the bruit? Is it in the proximal or distal?
Proximal.
Okay, our time is short. We have only a few more minutes. So what is your diagnosis?
Non-toxic multinodular goiter, sir.
With voice change?
With no voice change, sir.
No voice.
No voice change.
No voice change.
Okay. What is your plan of action?
What are the indications for surgery in multinodular goiter?
In multinodular goiter, if it is non-toxic, you can go ahead with subtotal thyroidectomy, sir. If it has toxic features, we can go ahead with antithyroid drugs and wait for a while to see if there is remission. Most of the times, there might not be any remission with antithyroid drugs. So I will wait until a euthyroid state. And in MNG, we can go for a subtotal thyroidectomy.
What are the indications? One is toxicity. What is that toxicity called? Primary or secondary? Secondary thyroid.
Secondary thyrotoxicosis.
Number 2, cosmetic reason. Number 3.
Cosmetic. Any compressive symptoms.
Yes, compression. In your case, this difficulty in swallowing. There are a lot of things are there. Number 4.
Retrosternal extension, if it is a.
Very good. Retrosternal extension from the inferior border of the MNG. Number 5. Follicular carcinoma. Long-standing MNG can turn into follicular carcinoma. For these reasons, we are supposed to do surgery. What surgery you will do?
Can it produce a papillary carcinoma?
No, sir.
No. What is the common? What is acethyrotoxicosis?
It's a toxic state in Hashimoto disease, sir.
No, she will produce a multinodular goiter. So the
Ah.
internodular tissue can go for a papillary carcinoma. So the commonest
Papillary,
now MNG, one of the commonest reason is Hashimoto's So MNG. So the old belief is always it is a follicular carcinoma. See, now number of incidents of follicular carcinoma is very drastically reduced. Even to some of the papers even started saying medullary carcinoma is more than follicular carcinoma. But papillary carcinoma can occur anytime. Even the internodular tissue of the multinodular goiter can turn papillary carcinoma. That's why your history should be appropriately, not only looking only the local, the lymph node enlargement. So here, what we are seeing on the left side separately, right side separate swelling, maybe a node. So you must be little more careful in this case doing a multiple FNAC and prove that it is not a malignancy. Okay. So what surgery you are planning for this case?
Subtotal thyroidectomy, sir.
Why subtotal?
Total. It's
Yeah,
either total or
both the
subtotal.
lobe is fully involved.
Yes, sir.
I never use the term subtotal. That is almost gone. You can either say total or near total.
Near total.
So this is a huge thyroid occupying the large both the lobes with the compression effect, with the tracheal shifting effect. What is the complication you are going to expect when you are doing surgery for this patient? What is scapular trachea?
Scabbard trachea, where hyaline rings of trachea become soft, sir, due to continuous compression,
That is
long-standing compression.
tracheomalacia. That is tracheomalacia.
The trachea is held from the MNG only, sir. When there is a removal of MNG, the trachea will collapse, sir. So there might be need of tracheostomy.
So you must be very careful in this case, especially because it's a large tumor for 30 years and already you are showing the tracheal deviation. So you must be very careful of doing a tracheal. What kind of tracheostomy you will do? Elective or emergency? What is the difference between elective tracheostomy and emergency tracheostomy?
Emergency in case if she had breathing difficulties, which she didn't have. Elective plan was
what is the
planned
surgical
after.
difference? What is the surgical difference? What kind of incision you make on the trachea? Okay, go and read all the time because the time is short. We are not going to that. Okay. So suppose you are done that and it turned out to be papillary carcinoma. The histology comes as a papillary carcinoma. What you'll do?
Near total thyroidectomy, sir. If
You
the
are
lymph
done.
nodes
You
are
are done
involved,
near total thyroidectomy, but the biopsy shows it is a papillary carcinoma.
If nodal involvement is there, we should see the central node dissection, and or if radio ablation can be used, sir, with iodine.
Straight away.
How
will you prepare the patient for radio ablation?
Post surgery, we have to give TSH hormone supplements. L-thyroxine should be given and reduce up to a point where TSH rises to 30.
Good. Go back and read all those things because it's important. No, once we don't think that it will be your question will be only on MNG. Question can be shifted to any part. Carcinoma you must be thorough. I think you have studied well. Your knowledge is good. Only thing, your clinical examination has to be little more focused and don't bring unnecessary things into the examination. Say what is only relevant to the patient and otherwise your performance is very good. Sir, because time is there, we can try to close it earlier, sir. Prabhakar, sir?
Yes, sir. Yes, sir. We can go to the next case, sir.
One moment, sir. Pooja ma'am, are you with us?
Yeah, I'm there. Actually, so many questions were being asked from her, so I thought let her
Maybe you
answer
can
that.
give your closing comment, ma'am, if something is missed or something.
No, I think this Anusha, can you tell about imaging, what imaging you want to do for her? I think that we didn't discuss in large factors.
We'll go for a USG, ma'am, to see for multinodularity and consistency and of composition. Then we'll go for we need a X-ray to see tracheal compression if it is the tracheal deviation and retrosternal extension. And then there is FNSE of the nodules is done to see the to see for if any carcinomatous changes are there. In this case, since it was a huge swelling, CT was also done to see retrosternal extension and tracheal status.
Okay, sure. Thank you.
Thank you.
Kirti Palmer sir is there. Is not. Kujar sir is. Sir, your favorite questions are not asked. Come.
What are the complications of multinodular goiter, Anusha?
One is it may progress to follicular carcinoma, sir. Then it might have compression symptoms, and then cosmetic issues and that's it, sir.
On my side, it is my last question. Before doing any surgery on thyroid, whether it is total thyroidectomy or subtotal thyroidectomy in this case, will you do video laryngoscopy for this particular patient, and why?
Yes, sir. For all the thyroid cases, we have to do video laryngoscopy because of medico-legal reasons, sir. There might be previous unilateral paralysis which might be compensated, and we might not know RLN palsy if it's present previously, and and the patient might be normal also with a normal voice, and post-surgery that might exaggerate. So we have to do it for medico-legal reasons.
How many percentage of people in normal population will have unilateral palsy, vocal cord palsy? And what is the reason for that unilateral vocal palsy in that percentage of people in normal population? 2 to 5% will have unilateral vocal cord palsy. The reason may be some viral infection in childhood. Okay? Right. Influenza, measles, like that. But you have done well, Dr. Anusha. Good.
Thank you, sir. Thank you, sir.
The rectal region or both adductor and abductors are paralyzed, no?
Abductor is posterior cricoarytenoid, sir, which is.
Is it both the adductor and abductor are paralyzed?
Yes,
or
sir.
not?
Yes.
But
Both.
why do you get in a paramedian position then?
Because of the cricothyroid, sir, which keeps it in
Cricothyroid has no role. That is only for the tensor of the vocal cord. So this is a homework for you. Go and read. Both abductor and adductors are paralyzed. But why the thyroid? I mean, this is in the paramedian position when it is paralyzed. To start with.
Okay, sir.
Which muscle of the larynx is called as the safest muscle of the larynx, and why it is called the safest muscle of the larynx? The answer is posterior
cricoarytenoid.
Because it is only abductor of the larynx. Okay, right. Yes, yes. We can go to the next case. Thank you.
Thank you, sir.
Thank you, Anisha. Did well.
Thank you, ma'am.
Thank you.
Thank you.
Thank you. Nice
Anusha.
presentation.
Anisha, you have any
Anusha,
question?
I request you to share your.
I am not able to hear, sir. Sorry, sir.
Any doubts to be clarified, Dr. Anusha?
No, sir.
Do you have any doubts to be clarified from the senior faculty here?
If you want to
No,
Now
sir.
we move on to the next case.
So,
Yes.
Anisha, you read Siemens law.
Yes, sir.
So you will get the answer for my question. Okay.
Siemens last. Okay.
Okay. Go ahead.
Thanks.
Good evening, sir.
Good evening. Good evening. Dr. Arya.
Yes, good evening, sir.
Voice is breaking, sir.
We can't start it because the host has disabled it.
No, Anusha has to stop the sharing. Anusha, you need to unshare.
Anusha, can you unshare your PowerPoint?
TCS.
Arya,
Yes, sir.
please share your PowerPoint. Please introduce yourself and start your presentation. Faculty, please take over. Thank you.
Sir, am I audible?
Perfect.
Yes.
You're good to go.
Good evening, respected faculties. Myself, Dr. Arya Singh. I'm the junior resident third year from the Department of General Surgery, IMS BHU. I'm presenting this case of epigastric lump under the moderatorship of Professor Rahul Khanna, sir. So this is a case of a 30-year-old gentleman, resident of Nepal, farmer by occupation, presenting to the surgical OPD with the chief complaints of abdominal pain since 5 months and lump in upper abdomen since 2 months. The patient was apparently asymptomatic 5 months back when he developed the complaints of acute onset pain in the upper abdomen, which was moderated intensity, stabbing in nature, gradually progressive and radiating to the back. Relieved on medication, after that it became on and off with mild intensity and dull aching since the initial episode. It was not related to intake of any meals and there was no aggravating factors. The abdominal pain was associated with multiple episodes of vomiting only during the initial episode, which was non-bilious, non-projectile, consisting of semi-digested food particles. It was also associated with a lump in upper abdomen since 2 months, which was insidious in onset, gradually progressive to present size, associated with dull aching and dragging sensation, and associated with the feeling of early satiety since 2 months. There was history of abdominal distension with non-passage of flatus in stool in the initial 2 days of the first episode of pain. Along with that, there was the history of hospitalization in the private hospital in Nepal only during the first episode of pain. However, there was no history of yellowish discoloration of eyes, urine, clay-colored stool, dark urine pruritus, altered bowel habits, constipation melena, or foul-smelling stool. Moreover, there were no complaint of fever, shortness of breath, chest pain, hemoptysis, or any antecedent abdominal trauma. There were no urinary complaints as well. In the past history, the patient had operative history of right-sided open mesh hernioplasty 14 years back in Nepal. And there was a history of ATT intake for 6 months, 18 years back for cervical tubercular lymphadenopathy, non-pulmonary. And there were no other known comorbidities in the patient. The patient had 6 siblings, all in good health, and there was no history of any such similar illness in the family members. In the personal history, the patient was on mixed diet with normal bowel bladder habits, normal sleep pattern. There was no history of any substance abuse, no known allergies. The patient, the gentleman was educated till 5th standard and was Yes, I'm summarizing the history. The 30-year-old male gentleman, non-alcoholic, presented in OPD, surgical OPD, with complaints of abdominal pain since 5 months in upper abdomen, which was on and off, associated with multiple episodes of non-bilious vomiting during the initial episode, with pain in abdomen. And there was abdominal distension, non-passage of flatus for the 2 days that was associated with the initial pain episode. And since 2 months, there's a complaint of lump in upper abdomen, which was gradually progressive and associated with early satiety. This was summarizing the history. Shall I proceed, sir?
What is the provisional diagnosis? The history.
So the provisional diagnosis in this case is chronic pancreatitis. That I have done after examination, so not just based upon the history. After examination of the patient.
The history itself. No, you have somebody comes with a severe pain abdomen, and after a few months they are developing a swelling in the abdomen. So what is by history? And early satiety is there.
Yes, sir. Just by the examination, just by the history, and the location of the lump on inspection, I could say that could be a liver pathology, or could be a pancreatic pathology, or could, because of the vomiting, I could say it could be an initial episode of gastric outlet obstruction. But then since there is only a single episode of vomiting, non-bilious, I will keep it lower in my diagnosis.
No, you have put a multiple episode of vomiting.
So
And
multiple episodes of vomiting was there, but during only during the initial pain episode, he had the vomiting, multiple episodes of vomiting. But after that, that vomiting
you are
episode
saying it is a non-projectile vomiting. That means it is induced vomiting?
no, sir, it was non-induced vomiting, sir. It was
So then what do you
associated
mean
with
by
the pain.
non-projectile? What do you mean by non-projectile vomiting?
Sir, it was the patient vomited fell near the it is near the projectile is not far away. It fell near the patient. You could
No,
say
that is not the way you are putting as a projectile and non-projectile. No? So only when you are going to induce, and that otherwise without any nausea, patient will suddenly vomit out.
yes, sir,
That is the central reason or other mechanical reasons acting on that. So here you must be able to explain. What is early satiety?
sir, patient developed early satiety since 2 months. That he
What
said
do you
he was
mean by
able to eat
early satiety?
compared to previous condition. The patient is able to eat less amount of food in the current status. Like he said that he's only able to eat 2 chapati in the whole day. He's not able to consume that much as compared to the earlier healthy
Due
state.
to what? What is the common cause?
Sir, it could be early satiety, could be because of the could be because of gastrointestinal pathology preventing the food from going in the forward direction, preventing the progressive motility. Could be because of any obstructive features, or it could be because of any non-surgical illness. For example, the appetite also decreases in conditions like
No,
tuberculosis.
we are not talking about appetite. We are not talking about appetite. There is a lot of difference between appetite and early satiety.
What is the commonest
The feeling
cause
of
of
fullness.
early satiety in India?
So tubercular
Commonest
pathology,
cause.
any tubercular pathology, abdominal tubercular pathology.
Absolutely no. Absolutely no. Intestinal abdominal gastric tuberculosis is a very, very rare entity.
They are never seen a tuberculosis lesion in the stomach. In the
It's a
intestines,
carcinoma of the stomach.
Yes, sir. Carcinoma, depending upon the age, is not. Yes, sir. Overall, most common cause could be carcinoma causing gastric outlet obstruction.
It's not due to gastric outlet obstruction. It is due to receptive relaxation of the bowel. When the muscles infiltrated, the stomach cannot relax. When you eat, the stomach will relax and more food will go. Here, the relaxation of the receptive relaxation of the muscles are lost, so that you will not be able to. The same with the pseudopancreatic cyst. It is compressing on the stomach cannot expand. The only reason is that it is due to the stomach is not able to expand and accommodate the food. So previously what you are eating, now you cannot eat, but your appetite will be there. You will still have a good appetite to eat, but you can't eat because of these two reasons. So there is a difference between appetite and early satiety, which we need to bring that. And you have said it is a stabbing pain. What do you mean by stabbing pain?
So the patient was telling as if someone is stabbing in the epigastric region. He had some stabbing sort of pain, as if he's being
How
stabbed
it
by a
differs
knife.
from pricking pain and stabbing pain? What is the difference?
So pricking pain is fine pain, as if some needle has been pricking over the area, and this
What is
is
the
a sharp
common
shooting
cause of a
pain.
stabbing pain? No, it is a very quick stabbing pain.
Yes, sir.
What is the reason for the stabbing pain?
Sir, because of stretching of because of the inflammation, there's the stimulation of parietal peritoneum causing severe pain because of the inflammation.
Where is the parietal peritoneum? Parietal peritoneum is coming very late, no?
It's
When
stretching
there is
of
the
the
masses,
capsule.
when the early part, parietal peritoneum is not involved.
The capsular stretching also causes severe pain, sir.
Which capsule?
The organ capsule.
What kind of pain when you have a capsule is stretched?
It can also cause dull aching pain, sir.
It is a throbbing pain. Whenever you have an abscess or the capsule is enlarging, it can only produce a throbbing pain. It cannot produce a stabbing pain. The commonest cause is the posterior gastric wall is penetrating, a perforation is taking place.
Ulcerative pathology.
Or even the severe pancreatitis, sometimes it goes. Even we will not say it is a very stabbing pain because it is like a boring pain. It's a slow, aggressive pain. We are going to get that. So, anyway, using the word, you must be a little cautious in using the word.
Sure, sir.
So, what made you to think it is a chronic pancreatitis? Because there is only one episode you are saying.
Yes, sir. The initial episode was there 5 months back. After that, the patient had the multiple episodes, as I had mentioned in the
That
history
is
of
not chronic pancreatitis. What is the definition? What do you mean chronic pancreatitis?
sir, multiple episodes resulting in the atrophy and calcification of the pancreas.
So you within 4 months, all these are going to happen.
The initial changes could start taking place.
No, you can say.
The
Here
inciting
you
factor
are
was
saying
months
there is a
back.
patient who is coming within them, and after 2-3 months he is developing a swelling. So it is better you talk with the in terms of acute pancreatitis. Okay, go ahead.
So, a general examination, the patient was conscious, cooperative, well-oriented to time-place person. The pulse rate was 96 with BP 140 over 68 millimeters of mercury, and respiratory rate was 16 per minute. Pallor was present, but there was no icterus, clubbing cyanosis, generalized lymphadenopathy, pedal edema, any signs of dehydration. The patient was moderately bent. On head-to-toe examination, there was no stigmata of CLD or no bruises or ecchymosis. On anthropometry, the weight was 57 kilogram, height was 165 centimeter, and BMI was 20.43.
So what previous slide? Go to the previous slide. Oh. What do you mean by generalized lymphadenopathy?
Sir, lymphadenopathy involving the cervical axillary, if there is multiple lymph nodes involved enlarged in multiple areas of the places, we could say if it could be a generalized lymphadenopathy.
So that is the definition. Is there any standard definition for generalized lymphadenopathy? If there is a 3 levels of nodes in the axilla, no?
Continue.
So yeah.
So contiguous more than 3 levels of lymph nodes involved.
Contiguous or non-contiguous? This is an undergraduate question, not for the postgraduate question.
Non-contiguous level of lymph node involved 2 or more than 2.
Because I asked this because many times nowadays we are asking the postgraduate, they are not able to explain this. So that means you are not reading the basic findings. No compromise should be there. And what are the stigmata of CLD?
This is the common skin in manifestation that we have seen in the CLD. For example, the palmar erythemas, the angiofibromas, as well as the skin
Your case
manifestation.
is only the total duration of your patient is only 5 months.
Yes, sir.
What are the features you will get in within 5 months?
So it is since the time duration is less for this to develop, sir. That I agree.
So you are looked for that spider.
As spider angiomas.
What is spider angioma?
The spider like the reticular the venous prominence on the skin
surface. It is a problem of a vein. It is arising from the vein. And what is the cause for that? And how many number of spider nevi is important?
So because of the in the CLD pathologies, there are various substance which is not able to get metabolized, resulting.
Substance. What is not metabolized? Substance. Okay, because if we talk on that, it will take a long time. But please go and read each component of the CLD stigma and for the reasons for that. Why there is estrogen excess and what is the mechanism? What is central arteriolar dilatation, peripheral reticular dilatation, capillary dilatation, and how do you elicit the spider angioma? You have to press at the center and you should see the blanching. And must be more than 9. So that's each point. Gynecomastia. How do you get gynecomastia?
Hyperestrogenemia because of
why there is hyperestrogenemia? Is the liver is secreting estrogen?
Unable to metabolize. The level will be going on increasing in the serum, causing spider angioma as well as the gynecomastia.
No, why? How do you explain the hyperestrogenemia? There is no apparent increase in the secretion of the estrogen. It is only the imbalance between the testosterone and estrogen. Because testosterone, the cirrhosis of liver, you also expect the Sertoli cell to be affected. There you cannot get the testosterone to be produced. Or testosterone binding hormones like globulin is increased. So more testosterone is bind. And alcohol per se can produce a phytoestrogens. So there will be ultimately the resulting in the relative increase in the estrogen in comparison of the testosterone. There is no absolute the increase of that. Because testosterone is low, you are getting a apparent feature. So each features of the stigmata. What are the stigmata of the chronic liver failure? Liver failure?
Sir, chronic liver failure may present as hepatic encephalopathy or asterisk flapping asterisk tumor, flapping of flapping tremors.
How will you grade encephalopathy?
Sir, grade 1, 2, there are 4 grades of hepatic encephalopathy. Sir, not exactly remember the diet.
Okay. Even your forgetfulness is a grade 1. Short span. So if your question is you are not answering, that can be considered as a grade 1. I'm just jokingly saying you are answering well. Okay, go ahead. I think Johnson, this is a surgical gastroenterologist, you can step in. Unmute yourself and ask some question.
Yeah, you are discussing about the chronic liver disease, sir. Go ahead, let her answer, yeah.
Oh.
Yeah, you can continue with the stigmata of the chronic liver disease.
She's not prepared for that.
Okay, no,
Okay.
then we'll
Go to the
proceed,
general
sir, we'll
exam.
proceed.
Go first.
Sir, proceed, sir.
Yeah, please proceed.
Yes.
Going to the abdominal examination or inspection, as the image shows, the abdomen is flat with umbilical central and inverted. A lump of approximately 14 cross 8 centimeter is seen in the epigastric region, extending to left as well as right hypochondrium laterally and inferiorly approximately 4 to 5 centimeters above the umbilicus. The lump does not seem to be moving with respiration, and the overlying scene appears normal. The scar of previous open mesh hernioplasty is seen in right inguinal region. There was no pigmentation, pulsation, visible peristalsis or engorged veins in the abdomen.
No, previous slide, Arya. Normally we ask only at the end, but I am here very shocked to see abdomen is flat. What do you mean by flat?
Sir, flat abdomen, sir, we do the inspection on the inspection of
But
flat
you have
abdomen.
an obvious lump in the upper abdomen and the lower abdomen is no lump. How can it become a flat?
Sir, well, patient lying on supine position.
Even then, in the supine position only you are examining, you are saying there is a lump.
Yes, sir.
Approximately 14 into 8 centimeter.
Large lump.
And it can never produce a flat abdomen.
Yeah.
So it was not very prominently seen on the surface as a prominent lump. Sir.
You are measured. You are even taking the measurement. 14
yes,
into 8 centimeter.
On the surface,
That is
sir,
obvious.
it was not bulging out, sir. The abdomen over in general appeared to be flat, sir.
Then you cannot say in the inspection there is a swelling. If there is a lump is there, only when it is visible you are saying.
Yeah.
See, you understand that. That's why I interfere in this here point.
Yes, sir.
Okay.
So continue, sir.
Yeah.
Yes.
No pigmentation. What you are looking for?
Sorry, sir.
You have said no pigmentation. Which pigmentation you are looking for?
Sir, any nevi, as I said.
Why you committed that pigmentation? Sir is asking that.
Sir, any skin pigmentation or nevi, I meant by I just meant that, sir.
Don't get into trouble. And
No.
tell me what is nevi? What is nevi?
In what way it is related to the epigastric masma?
Epigastric, that's all.
In this case, it is not related, sir. The pigmentation.
It's not related. It's not related. I'm saying the pigmentation is related.
Okay.
What is Gray Turner sign and Turner sign?
Sir, in the case of pancreatitis, we see the bruising.
So you are talking about pancreas. You are suspecting a pancreas. So you should have explained in that way. Though we are not going to have it. It's only hemorrhagic pancreatitis you are going to get. But when you have said no pigmentation, you should be thorough. It's not just routinely what you are saying. With related to this case and what are the areas we are going in. Don't bring nevi and all here. Okay.
What is Gray Turner sign?
Sir, thyroid patch or bruising that is commonly seen in the flank region in the case of hemorrhagic pancreatitis.
Okay, right.
Cullen
Go ahead.
Okay, go ahead. Go
What
ahead.
is Cullen sign?
Sir, similarly, we can see a chemotic patch or bruising around the umbilicus, sir. That is known as, because similarly in the hemorrhagic pancreatitis only it's seen.
Okay. Good. Go ahead.
So how would you identify it with the inguinal scar? It is a herniaplasty, not a herniorrhaphy.
Sir, I did not say it was. Sir, he had a history of mesh placement.
Okay, you have set it in the history, no?
He was
Okay.
telling, he had given me the history key mesh was.
Okay. Scar was normal.
Yes, the scar was normal. It is not very prominent in this picture, but it was normal. Appeared was
Okay,
healed normal. So on palpation, there was no local rise in temperature.
Side
Mild
view
pain.
also, it is not a flat mass. The epigastric mass is clearly seen. Side view. Okay, go ahead.
There's no local rise of temperature. Mild tenderness is present. There's no rigidity or guarding. A single 15 cross 8 centimeter vague, immobile, smooth surfaced lump is palpated in epigastric region, extending into both left and right hypochondriac region, which is firm in consistency. The upper border is felt 4 centimeter below xiphoid process and 3 centimeter below left and right costal margins, and I'm unable to insinuate the fingers below the costal margin. The lower margin was felt 6 centimeter above umbilicus and laterally extending 8 centimeter from the midline to the left and 7 centimeter from the midline to the right hypochondrial region. This was the extent of the lump that I was palpating. There was no other lump or organomegaly noted. Bilateral renal angles was non-tender and spine was within normal limit. On percussion, dull note was present over the lump and liver span along the mid-clavicular line was approximately 15 centimeter. Shifting dullness was absent. On auscultation, normal bowel sound was heard and was no bruise. On DRE,
Okay, okay. Finish your.
on DRE, the perineal skin was normal. There was no any abnormalities. Mucosa was normal, mobile, no palpable growth or swelling. Fecal staining of glove finger was present and there was no blood staining seen. External genitalia was within normal limits. And on proctoscopy, there was no rectal varices or hemorrhoids noted. The systemic examinations, both all the central nervous system, cardiovascular, respiratory system, were within normal limits. Summarizing it, 38-year-old non-alcoholic male with upper abdominal pain since 5 months associated with non-bilious vomiting, early satiety, and 15 cross 8 centimeter firm non-mobile lump in epigastric region extending to both left and right hypochondrium with lower margin 6 centimeter above umbilicus, not moving with respiration, becoming less prominent on head raising was seen. I've already shown you my provisional diagnosis, sir. Provisional diagnosis according to this examination was pancreatitis with pancreatic cirrhosis as a sequelae.
What are the points in favor of your diagnosis of pancreatic pseudocyst? Why do you say?
Sir, first of all, sir, the lump was not moving with respiration. It was restricted. It was non-mobile lump, sir. And on checking if it is and intraperitoneal, it was intraperitoneal, and
You said it is moving with the respiration.
that does not seem to be moving with respiration, sir. I'll show it.
What is the commonest cause for pseudocyst of pancreas in India?
Sir, pseudocyst of pancreas, it is commonly seen after chronic sequelae of acute pancreatitis. It is
So sequelae of
acute pancreatitis. So it can
due
develop.
to which acute pancreatitis?
Sir, most commonly it is because of
Alcoholic acute pancreatitis. So your patient is a non-alcoholic.
But our patient is a non-alcoholic pancreatitis.
So what could be the cause?
So
He
it
complained of a severe pain, excruciating pain.
Sir, other causes, I will try to rule out the other causes of that is common for causing pancreatitis, for example, gallstone-induced pancreatitis.
Okay.
Or since I have taken the
How
history
do
of trauma,
you rule out there is no cholecystitis or stone in this case?
sir, just from the palpation, I will try to
The
palpate.
history started, no?
The history, there was, I asked if there is any complaint of dyspepsia or bloating, gas bloat syndrome, or any
Acute
bloating.
cholecystitis need not produce a dyspepsia or bloating sensation.
It might
Can present with a severe pain.
Okay, sir. Yeah,
Your
and
patient
I asked
also
the
present with
history
a
of,
severe pain.
is it right hypochondriac pain or fever? I've asked that history. It was negative.
So have you checked for a Murphy's sign?
Sir, it was not present in this case. And when
You are not
presentation,
mentioned, you are not said. See, what we want to see, how broadly you are thinking of that. Because you are very categorically saying it's a non-alcoholic patient.
yes, sir.
So non-alcoholic patient, you should try it out. The other next commonest is gallstone. So you should, your test, your examination should be say the gallbladder is normal.
Yes, sir.
You understand? See, if it is, you say alkali pancreatitis, yes, you have not gone into that gallbladder. Here you need to go into that gallbladder and find out. And have you checked for intrinsic mobility?
Sorry, sir, have I checked for?
Intrinsic mobility.
So it was not mobile, sir. The lump was not mobile. That I have mentioned in the. That's why I'm suspecting it's not, since it's not a mobile lump, not moving the respiration.
So you don't have any DD? I'm saying it could
Yes,
be
sir.
a gist.
So again, sir, I would say since GIST is known to be a mobile, it's a
May
mobile
not be.
marker.
The posterior gist can be a fixed one also. It moves with respiration. Intrinsic mobility may or may not be there.
So it is neither moving with respiration and it is not having a mobility. Moreover, sir, the features of gastric sleeve obstruction was seen only in the initial episode, not constantly seen after that.
Yes, sir, I think your audio is
on.
Okay. Go ahead, Tanisha.
And moreover, the obstructive, the vomiting, the feature of vomiting was seen only during the initial inciting episode. That was even though it was multiple episode, it was seen only in the initial.
That is again picked in towards the gallbladder pathology.
And sir, again, if to see if it's a since I've made a differential of a retropancreatic lump, the peritoneal lump, I'll see.
How a stone in the gallbladder can produce a cyst, pseudocyst of the pancreas?
Sir, first of all, the stone in the gallbladder does not go and directly produce a pseudocyst of pancreas. It causes acute attack of pancreatitis. There are two proposed theory, as you know, that is the reflux theory and the obstructive theory. The stone from the biliary tract can either obstruct the ampulla of Vater or the main pancreatic duct. That can result in pancreatitis, and as a sequelae of pancreatitis, you can get a pancreatic pseudocyst.
Okay. Right.
Okay.
Then what is your next diagnosis?
Differential diagnosis, you have put as a pancreatic abscess or walled up necrosis. What's the difference in these two?
Sir, abscess, if the collection is infected, so that's what I meant by if it's infected, it could be a walled off necrosis or an abscess.
So cystic neoplasm of the pancreas will be so large.
So initially it starts with the smaller size. It does not become large all at once.
18 into 14 centimeters.
Pancreatic abscess you will get in acute pancreatitis or in chronic pancreatitis?
Sir, if it is infected, after 4 weeks, infected collection is known as walled off necrosis.
So, I'm asking the question, is it a sequelae of acute pancreatitis or chronic pancreatitis?
Sir, acute pancreatitis post 4 weeks in the chronic state.
Okay.
Yes. Okay. Chronic pancreatitis is very common in Kerala or in Tamil Nadu.
Sir, Kerala, sir, I would say. Sir, cassava, not that sure, sir, but intake of cassava. Tapioca's intake can result in chronic pancreatitis.
What made you to think it is a liver abscess?
So left lobe of liver abscess, the
extending
location,
up to the left hypochondrium.
Yeah, since sir, the typical location.
Your upper border is palpable.
Sir, in this case, sir, it was in the left. That's why I put in a lower in the differential, sir. It's in the left hypochondriac.
Why do you want to bring that liver abscess here?
Yeah,
never had a history of fever. Never had you talked about the intergastritis. Your upper border is palpable. You said.
But the liver abscess, the amoebic liver abscess is very common in the right lobe or in the left lobe?
Sir, in right sided.
And in right lobe means in which segment?
Segment sir, 5, 6.
5, 6, 7, 8, all these things you are telling. 7. Seventh segment. Why it's very common there? Read
Sir,
it.
sir?
Okay.
Sorry, sir.
Is it common in a menstruating woman, liver abscess?
I don't know why it's common in menstruating women.
It's not common. In fact, it very, very rarely occurs in a menstruating woman because of the ferritin load. The liver will have a ferritin, the storage ferritin will be low. So that is a protective feature against an amoebic liver abscess. So normally we don't see in a menstruating woman a liver abscess condition. So here I don't think you can bring in a liver abscess. If you would have talked about little pancreatitis, non-alcoholic pancreatitis, probably the gallbladder pathology, or why you are not saying it is stomach mass?
Sir, it was again not moving with respiration, not causing obstructive symptoms. There was only a single episode of obstructive vomiting symptoms that was seen. That's why I've not put any stomach mass in the differential, sir. Only one time it happened during the inciting episode. That time only it was multiple episodes, like 3 to 4 episodes at once within the span of 2 days. After that, he didn't have the feeling of nausea or vomiting.
Such a large mass compressing on that to the level of early satiety, how will you justify he is not having vomiting? You are saying 14 into 8 centimeter mass. That means it's definitely compressing the stomach. That is why he is having early satiety. So he is able to take food now.
Sir, he is able to take, but in less amounts, sir. So
intermittent vomiting.
Since 2 months.
No, without vomiting. She says there is no vomiting in the last now.
Yes, sir, I had confirmed that. Even I was skeptical about it, so I asked him multiple times.
Good, that is fine. That is a good answer, ma. If you are saying I have confirmed it, that is a very good. You must have a doubt and explain. So don't change that. Don't for the examination point change that finding. If the patient is saying that same, you can still explain, and probably it is not compressing at the pyloric end or something else. You can think of the reason. It's only maybe affecting the upper end. Okay. So how you are going to proceed?
Why can't it be hydrated cyst, Arya?
Sir, it can be, sir. It can be a hydrated cyst, sir. It could be a hydrated cyst.
Hydrated
But then
cyst
again, sir,
from the liver or from the pancreas?
Liver hydrated cyst. Liver.
What is the commonest site in the abdomen? It's a liver.
Yes.
Second commonest site of hydrated cyst in our body?
Lungs.
Lung. Yes. These are the two commonest sites, liver and the lungs. Okay. What is the
any
constitutive
question in the examination?
Sorry, sir?
No, I'm asking the examiner. Dr. Johnson? Professor Johnson?
Yeah.
Any questions on the examination part?
Examination, okay, sir. Okay. You can proceed.
So how you are going to manage?
Sir, I will first conduct series of investigation, blood as well as radiological investigation, sir.
Why do you want a blood investigation now?
Sir, first I will conduct an USC, sir, ultrasound whole abdomen.
First, is only a confirmation of your diagnosis.
Yes,
postgraduates don't come in a routine blood examination. It's the first thing. First, you need to confirm your diagnosis. Okay. How do you going to confirm?
So I have first performed. I've gotten a USC whole abdomen done. So patient presented with USC whole abdomen through.
What frequency probe you will use?
Sir, 2.5 to 3.5 low frequency. Sir.
Low frequency, 2.5 probe. You are having a 2.5 probe in your hospital.
3.5 to 4.5 megahertz, sir.
Normally, it is a 5 megahertz. 3 was an old concept. Now, abdominal ultrasound. Are you able to do the ultrasound, or you are still depending upon others?
Sir, certain cases, sir, if I am able to do, but if you want to know detailed pathology, then.
That is true. But you must, as a postgraduate, you must learn to do the basic ultrasound. So you are made out, how will you make out a pancreatitis in an ultrasound?
Sir, in this case, sir, ultrasound was showing a cyst, a large lesion with the collection in a very close relationship with the pancreas as well as the lesser sac of the stomach, closely abutting the stomach as well. And it showed it had other significant findings as well. And that made me, and that was feature suggestive of pancreatic pseudocyst, and as well as the pancreas were appearing very bulky. Duct was normal. We'll see the status of the pancreas, the cyst, the surrounding structures, the status of the surrounding structures, relations with the cyst.
Is it communicating or non-communicating?
UAC, it is
It is a
difficult.
communicating cyst or non-communicating cyst?
So, on UAC, I can't comment on this, sir.
On all this, you can make it to an ultrasound?
No, sir. For communication,
Okay.
ductal communication,
So what you could brought out in an ultrasound?
sir, the
What are
location,
the features you could identify?
sir, the location, the status of the pancreas first, the status of the stomach if it is distended or not, and the status of the cyst that is being shown in the UAC, sir. If it isn't the exact location, the volume.
Can
This
you
can
get
be
multiple cysts? Can you
possible.
get multiple cysts? So you can see the number of cysts and
number of
what is the
cysts, yes,
extent and where it goes. All that you are going to make out and content, whether it is a clear fluid or whether any residual matters are there. All that you can make it out. Okay. The next.
Then next, sir, I will do another advanced radiological imaging, that is the CCT whole abdomen. Before that, we'll do the blood investigation. So I would like to perform the blood investigation. And then CCT whole abdomen, sir.
You are going to do the whole abdomen or pancreatic protocol CT?
Sir, in just for pancreatic pseudocyst, I would say pancreatic protocol will be pretty much expensive. And with CCT whole,
Why it is pretty much expensive?
we can get it, so we'll get a better cut, smaller section, less than 3 mm.
What are the criteria of a pancreatic protocol CT?
Most commonly, sir, pancreatic protocol is done in the case if you're suspecting any malignancy or growth.
No, what is the difference in other liver protocol and the pancreatic protocol? What are the major differences?
So the first are the slices, the cuts. It is less than 3 mm cuts.
Very good. So you need to do the rapidly, you have to do the examination. Then slices should be small. So you know that. So you want a whole body CT or whole abdomen CT?
Whole abdomen, sir. CCT whole abdomen.
Okay. So what are the things you are going to make out in that?
Sir, first of all, now since we have the advanced modality, we can see the exact location and the size of the cyst. Along, we can check. Very important
how will
thing
you
is
grade
to
that?
check for. Sir, sorry, sir.
DDQ classification. How will you grade this pseudopancreatic cyst? You are aware of that?
I've heard the names. I've not gone through the.
So basically you have to find out whether the pancreatic duct system is normal or the cyst is communicating with that. And what is the status of pancreas, whether it is an acute pancreas, normal pancreas, or whether it is a distal pancreas. So it's the 4 stages, DDQ classification. There is the 4 stages are there. So depending upon that, if it is because the treatment is going to decide upon that, if it is a communicating or kind of thing. And also what else you have to look for?
Sir, we look for if there is any pseudoaneurysm. If in case.
Very good. Why do you get a pseudoaneurysm?
Sir, because of the pancreatic enzyme that causes the weakening of the walls of the blood vessels, resulting in pseudoaneurysm. That could be a reason.
Which vessel will go for aneurysm commonly?
Sir, it could be a splenic vessel. The vessel's proximity with pancreas.
So what else you are going to assess? What are the most important criteria you are going to assess in the CT?
We have seen for ductal communication, sir, and we'll be seeing the wall thickness, sir, mature.
Very good. Okay.
We'll see what's the thickness of the wall, if it has matured or not, as well as the distance of the wall from the stomach.
Very good. And it's the proximity, whether it is to the posterior wall, whether it is proximity to the duodenum, and where it is a close proximity is there, you have to assess for that. What else?
Will
you do endoscopy?
Sir, endoscopy, if I'm suspecting any sort of splenic.
Is there any role of upper GI endoscopy?
It can be, sir. It can. There could be a role. If there is a splenic vein thrombosis, that could result in portal hypertension. We can do an upper GI endoscopy to see the dilated fundal vessels. Varices. To rule out that.
Can endoscopy play a therapeutic role?
Yes, sir. Endoscopically guided drainage cystogastrostomy. If that facility is available in the setup, in that
So
case.
What is the rule of 6 in pseudocystic of pancreas, Dr. Arya?
Sir, if the rule of 6 states that if the size is more than 6 centimeter and if it has persisted for more than 6 weeks, it is the indication for intervention.
Another 6. The wall thickness.
Wall thickness 6 mm. If it is more than 6 mm, that wall is said to be mature.
what is the weightage for the rule of 6 nowadays?
Not that it is not.
So what is the weightage now?
Less weight, so it is not that commonly
So
followed now.
more importance, what do you give?
Symptomatic, if the patient is
Symptomatic.
symptomatic or not, we have to see that primarily.
So what are the options in front of you now? You have made a diagnosis. It's a non-communicating pseudocyst in the lesser sac.
Non-communicating pancreatic pseudocyst, sir. The options can be, sir, if this setup is available, could be endoscopically guided internal drainage or surgically managed.
You are not going to plan for internal drainage or external drainage?
Sir, internal drainage, sir. In this case, internal drainage.
What are the indication for external drainage?
Sir, external drainage is done in the case of infected pancreatic pseudocyst, or if the patient is having morbidity, making him unfit for the surgery. That could not leave him to get operated under lap or open procedures. So you can do a percutaneous drainage. In most likely, intragastric percutaneous drainage is better option.
So you are planning for an internal drainage?
Yeah, in this case, planning for internal drainage.
What are the options in front of you?
So laparoscopic or open internal drainage, cystogastrostomy.
What you will prefer at your institution and your level?
So laparoscopic cystogastrostomy.
Okay. So tell me how you are going to do.
Sir, first we'll give an upper midline incision, and
You said laparoscopy?
yes, sir, laparoscope. Yes.
No, you said you are going to do laparoscopy, then you are suddenly making a upper midline incision.
No, sir, in this case, it was done openly, sir. I have seen open,
okay.
sir. I have not seen lap.
That's what I asked you. What you prefer? Huh? It is not the.
I was asked specifically.
I prefer open, sir.
Okay, go ahead. Nothing
in
wrong
this
with
case,
that.
was done open only, sir.
Okay, go ahead.
Okay.
Upper midline incision under what anesthesia, ma?
General anesthesia, sir.
Hmm.
Under general anesthesia, supine position, the upper midline incision was given, and after opening, first the hand is swept over the anterior gastric wall to feel the bulge, if palpable. Then in the anterior wall of the stomach, gastrotomy has been made, and then the posterior wall
What
of
is
the
the size
stomach.
of the incision? Vertical or transverse incision? What is the size?
So transverse incision is given. So transverse incision.
Transverse is given, preferred. Okay. So lesser curvature to greater curvature.
No, sir, at the area of bulge, not entire.
Then?
And then the posterior wall of the stomach is visualized, and then we see for the area of bulge.
The posterior wall of the stomach, how will you know that whether the cyst is underneath or not? How will you confirm?
So the bulge, first of all, we can see the bulge, sir. And moreover, we have already done the diagnostic modalities that showing the relationship with the stomach. We can feel the bulge, and also we can do aspirate, sir.
That is
must aspirate and
Needle aspiration has begun.
Yeah, needle aspiration before making a nick.
But unfortunately, when you made an incision on the posterior wall, there is a sudden hemorrhage is happening place. It is bleeding profusely.
Pressure, sir, pack and pressure. I would go with the pressure, pack and.
Good. Right. Anything else? What you can do?
It's better to close up the case. Or
close up the case means it will continue to bleed. No?
Sir, if we have to search for the site of bleed and ligation, intragastric ligation.
You can make a circumferential stitches, because these are mostly because of the dilated pseudoaneurysm veins. And if you are confident, you can take a suture and crisscross switches circumferentially, hemostatic stitches you can make. So that will be always better. Okay? Nothing to be worried. In the postoperative
Yeah.
period, you have a lot of option, this
Embolization.
embolization, all that things that on the table it is in front of you. You must know.
You have to ligate the splenic artery on either side of the cyst.
Okay. So then you have anastomost.
The posterior wall of the stomach with the cystic wall, the wall of the cyst.
Okay. So you have closed the abdomen, and when will you ask the patient to eat?
Sir, initially, sir, bowel rest is preferred, sir.
How long?
When you ask the patient to eat, the food will enter into the pseudocyst cavity, isn't it, or not?
No, sir, it is a dependent drainage, sir. The food will go into the stomach, not into the
Dependent drainage means it will go there.
dependent in the stomach, sir, not going back from it.
No, cyst is not anterior to the stomach, no. It is in the greater curvature
Posterior.
and the posterior to that only there. So when you have made a large opening there, it is naturally the food will go towards the greater curvature and it will go into the cyst.
The stomach is having the pressure changes in the stomach also will be the receptive relaxation of the stomach, and the
Okay, so
pressure
one is the
changes.
pressure. What is Venturian effect?
So if there is a small narrowing followed
No.
by a great.
When the via naturalis is patterned, the side hole will heal. That is the law of the Venturian effect. So since whether your GI tract propulsus and the peristalsis is there, it will push the contents towards the duodenum and it will not go into your
cyst.
cystic cavity. So you are closed and you have come out, but the second day onwards he is doing a hematemesis.
So we suspect any pseudoaneurysm rupture with
Okay.
ductal communication.
Or even your anastomotic side, something is
Leak.
bleeding. So
The
what do you
hemorrhage
do?
from the suture sites will ideally, to prevent that, we have to take a continuous interlocking underrunning suture to anastomose between the posterior wall and the cyst wall to prevent the
But this patient has hematemesis now.
Surgery is over. Now the patient is having hematemesis.
Postoperatively.
First, we have to see how much is the amount. If we can observe the patient is vitally stable, we can observe.
So,
If not, we can
when the patient is bleeding, by the amount of blood coming out through the mouth, you can assess how much is bleeding. Because partly it can go to the melena, no?
So we can take the help of radiological DSA.
You are the only surgeon available there. You are trained in endoscopy.
Sir, upper GI endoscopy. Attempting an upper GI endoscopy.
And identifying the site, and if
Course
it
of
is
the
possible, you can coagulate or anything, something which you can do. That is the first line. If it is not there, then you can go for which artery will bleed more. When there is a stomach, posterior stomach is involved.
So the
Gastroduodenal.
So it's the gastroduodenal artery will be the culprit. So otherwise, you have to open and identify the gastroduodenal artery, and you can ligate that patient. To your surprise, the biopsy comes as a pancreatic carcinoma.
Sir, for that, we'll have to do we have to continue with the staging, and then we'll have to proceed with the chemo. Then we'll start with the definitive. We have done already. We have found the carcinoma. I will try for R0 resection.
Johnson, you can ask some question on that.
Yeah. If it is malignancy, we can't go for resection. Is it possible?
No, so we can have an
The
approach.
intent of the treatment is now it's not curative.
Yes, sir. A palliative with multidisciplinary approach can be followed, sir. Palliative and multidisciplinary, we can do further investigation to stage the. In this case, we can do the further staging, and you can plan the treatment after that.
Okay.
Suppose it is communicating with the duct. Did we go 3 or 4 where we are giving the chronic pancreatitis with the duct is communicating?
Sir, have to confirm after confirmation of the ductal communication, do sir stenting ERCP can be done, sir, attempted to
Pancreatic
allow
stent.
the transpapillary drainage can be allowed in the internal drainage.
Okay. That's the best option. Otherwise, on the surgery side also, you can look for that. In the posterior wall of the cyst wall, you can look for that. If you can identify any communicating cavity, there you can suture it also. Or it is ideal to put an acid. So can you get a cirrhosis near the colon?
Sir,
What are the other sites you can anastomose?
sir, we can get gastrocolic site of the pancreatic cirrhosis. That is the site less common. If in that case you can plan for a cystogegenostomy, Bruin cystogegenostomy.
Suppose you have multiple,
So,
one large cyst at the lesser sac and other 2, 3 small cysts.
so for
Will you
we
go for
can make
doing
the
all anastomosis?
no, so the larger one we can do the anastomosis. Other rest of them we can just aspirate and
It will be intercommunicating most of the time.
So it will be always settled down. There is
yes,
no need for going
self-resolving.
for other things for that. So is it
What
chronic?
are the other? Yes, sir. What are the huge masses in the abdomen that can disappear on its own? Disappearing masses. Very large masses. Dr. Arya?
Yes, sir. Yes, sir.
Any crisis?
What is Tidal's crisis?
Sir, details crisis in the case of in the renal pathology, sir, because of any obstruction in the urinary pathway, there is accumulation of the urine causing a dilatation of the kidney, making it palpable. The mass is palpable per abdomen, and after the passage of the urine, it settles down. And that's the details crisis.
Hydronephrosis. Yes.
In the case of hydronephrosis.
Number 1. Number 2, communicating pseudocyst of pancreas. Okay, number 2. Number 3, ascariasis, ball in the intestine. Number 4, impacted fecal mass. These are all the things that will disappear. Okay, right.
What is acute fluid collection? What is pseudopancreatic cyst?
Sir, acute fluid collection because of inflammation within 4 weeks. We can both distinction has been done on the basis of the duration.
How will you
Within 4
manage that?
weeks. Sir, acute fluid collection, conservative expected management. Sir, we don't actively go and do it if the patient is stable and there is no symptom. We don't try to. It gets resolved, sir. And after 4 weeks, if it forms it generally forms pancreatic cirrhosis, and if in case that is causing symptoms, or then we can plan for intervention. Sir.
So what you are going to do? Why do you call it as a pseudopancreatic cyst? Why not it is a pancreatic cyst?
So because of the wall of the cyst is made of collagen and inflammatory cell, not because of not of the true epithelial layer.
So your patient after the surgery, patient develop a pancreatitis. That is also possible because you are using enpromacin. So how you are going to manage that?
Sir, conservative management. We have to do expected management, sir. Provide IV fluids.
So you will not try that. You will not try. There is no scores for that.
So post cystogastrostomy pancreatitis, sir.
Yeah, there is patient now has features of acute pancreatitis.
Yeah.
What are the scores or the methods you assess that, grade that?
Sir, acute pancreatitis scores are Ranson scoring system, CTSI scoring system, a revised Atlanta scoring system.
Okay.
Is Balthasar grading?
So Balthasar scoring system, Balthasar grading is also done for acute pancreatitis, severity of acute pancreatitis, and various parameters is there.
CT can also say it is a mild, moderate, or severe pancreatitis.
Yes,
suppose it's a mild pancreatitis, what is your line of management? If it is a moderate, what is your line of management?
So in the case of mild pancreatitis, we will again will give a supportive management of IV fluids. Will manage the pain and oxygenation, and the patient is expected to resolve on his own. And
Is allowed to take oral feeds or not?
So delayed delayed oral and soft diet, semi-solid soft diet is preferred, sir.
Very good. There is no need for putting the patient on a starvation.
Yes, sir.
Okay.
Early enteral feeding, yeah.
Early enteral feeding is preferred.
Why do you prefer enteral feeding than parenteral feeding?
Sir, enteral, sorry, sir, I didn't.
What is the advantage of enteral feeding over the parenteral feeding?
Sir, first of all, the bowel motility is bowel motility will be enhanced in the case of early enteral feeding. Plus, the level of amount of pathogen in the bowel will also be reduced in the case of early enteral feeding. The colonization will
There
not
are
be.
almost 9 to 10 reasons.
Sir, the epithelial barrier of the stomach will
Very good. Epithelial barrier is broken. So then
will be more enhanced in the case of early enteral feeds, causing early bowel motility, and prevents the bacterial mobilization, sir. Proximal bacterial mobilization.
the transudation of the fluid and the immunity of the gut, cost effective. So
Yes,
there
sir.
are a lot of reasons that
Inflammatory
always you
is also
prefer.
there, sir.
The gut mucosal barrier is also preserved.
Yes,
So-
sir.
That prevents the bacterial translocation in the systemic circulation.
That's the main cause. Otherwise, the bacterial translocation can take place. So what is the role of activated? What is activated?
Sir, stomatostatin analog, sir, that is given in order to decrease the secretion, because stomatostatin will inhibit the secretions from the cells of the pancreas, both the bicarbonate and the enzymatic secretion. But sir, in this case, or in the pancreatitis, sir, it is not preferred, sir. It does not have a significant role. I wouldn't do it. Wouldn't give pancreatitis, sir.
Unless it is sometimes hemorrhagic pancreatitis.
It is
So
of
that is-
not of more use, sir.
What will we do for the wall of necrosis?
Sir,
You are putting a
walled off-
pigtail. You are putting a pigtail, but it is not draining.
Sir, we can try for either if the patient is if the patient is symptomatic, and then we can try for open or open necrosectomy, sir.
Very good. Try for a necrosectomy for that.
Why the serum calcium level is very low in a case of acute pancreatitis?
Sir, acute pancreatitis causes dystrophic calcification that results in saponification, and the enzymes will be using up all the calcium because calcium acts as a coenzyme. So
Among
that
the-
will result in.
Can you show your CT?
Sir, this is the CT whole abdomen reporting.
No, show the picture.
Yes.
Picture.
Read the CT.
Sir, the CT shows the well-defined lesion that is seen abutting the stomach, which we can see the stomach is
Well-defined hypodense lesion. Where?
hypodense lesion, just abutting the stomach, sir.
Wall. Well-defined wall.
Sir, in this the
Thickened wall.
So in this section, sir, we can see it is as a separated collection, but in the sagittal we can see it's a continuous communicating single collection, sir, and it is close, and it is very close proximity with the stomach, closely abutting the wall of the stomach, and
Cystic content.
the content, sir, in this it appears to be hypoenhancing content, no, not appearing more like a necrosum, sir. The content is more likely of not ecogenic, not unecogenic contents, and not enhancing debris or necrosum.
Status of the
No,
pancreas?
is there any contrast extravasation?
No, sir, there is no contrast extravasation, sir. Communicating, you can see this is a communicating whole cyst abutting
Okay.
the stomach posterior wall, very close, lying in the wall of the stomach.
Is there any evidence of chronic pancreatitis?
Sir, the pancreas, according to the reporting, sir, it is appearing bulky. In this case, there is no evidence of chronic pancreatitis, as the ducts is normal. There is no atrophy.
So it can be acute
There is no
pancreatitis.
evidence of chronic pancreatitis, I think.
Sorry, sir.
I think there
So
is.
chronic pancreatitis must be atrophy, no?
Not
that's-
sir.
So here the parenchyma is preserved. Parenchyma is normal.
Yes, sir.
Yeah,
Yes,
there's no evidence of chronic pancreatitis.
calcification.
Oh,
Looks like acute pancreatitis only.
acute pancreatitis.
Yeah.
Good. Any questions you have?
Sir, I would like to ask that in the case of abdominal pathologies, how do we like in this case, there was an epigastric lump, and I've been asked, what should be the order of differential diagnosis in the case of retroperitoneal, if we're suspecting retroperitoneal lesion, sir? If it is not,
No, this case is very obviously, Emma. You have a typical episode of a pancreatitis followed by the fluid collection. So you can definitely you can put as a, I mean, I will not prefer a chronic pancreatitis. You can acute pancreatitis with the pseudopancreatitis cyst will be your first answer, the ideal answer.
the answer,
Other answers, you don't bring in liver abscess and all here. The other thing is you are very obviously no symptoms of any toxicity. Patient is absolutely normal, symptom free.
Don't say pancreatic abscess and all.
okay, sir. Yes, sir.
If the tumor and all will not come here.
Tumor also, it is also huge. Only suddenly within 2-3 months, you are going to see it's not going to be. See. And second, if it's a tumor, the patient will present with a lot of gastrointestinal symptoms also, because it will be in the C tube, C lobe. No? The only thing you must know the classification of the pseudopancreatitis cyst, and you need to know whether it is acute or chronic pancreatitis, and whether it is the connecting system, that the pancreatic ducts are distorted, communicating, all the things which is you can see. And if necessary, you can do what tumor marker you will do.
Sir, I would prefer CEA and CA 19.9.
That is also it's a rare possibility. And if you are suspecting malignancy, are you satisfied with the CT or will you go for MRI?
So MRCP will help us in showing the ductal communicate, the involvement of ducts in the both pancreatic and the biliary ducts, both.
If it is ruptured into the peritoneal cavity, how will you manage, Dr. Arya?
Sir, we can put, sir, drain can be put, sir, intraperitoneal drain. USG guided drain can be put, sir, to drain the initial collection until the patient has been stabilized. And we'll start with the supportive management.
Okay. Can I will, sir?
Okay. Good.
Can
Sir,
I will,
yes,
sir?
sir. Yes, sir.
Okay.
Sir, we can allow her to ask any questions and then.
He has asked one question. Now you can ask her any more. Okay. But you said some portal hypertension cases there today, no?
Sir, that will be for the next week, sir. In fact, now it has become suddenly competition. 5 people are waiting. I find difficult to accommodate now people, sir.
Okay. Both the
Actually,
candidates have done well. Arya has done extremely well. And she's
Sir,
very
credit
confident
to
of her findings,
Professor.
confident of her clinical findings, and even some of the critical questions she was able to come
Yes,
out
sir.
with.
Actually, she is from Rahul Khanna sir's unit from IMS BHU.
Okay.
So full credits to the department and the standards which they have set for the academics, sir.
Great, ma'am.
Great.
Any other faculty would like to ask any questions, or with the permission, can we call a close?
Yes, sir.
Thank you very much.
Thank you.
Sir, next week we have a case of portal hypertension and 2 more are waiting. Maybe I'll put in the group and take the consensus which case will go for the next week, sir.
I think portal hypertension, because since a long time we are not discussed.
Yes, sir. Yes, sir. And the PowerPoints as I receive, I'll put in the group, sir. And as the seniors
I saw
vote
that.
for.
I saw that is I decided to be with this. Okay. Anyway, it is good today. Good.
Yes, sir. Yes, sir. Thank you, Arya. Thank you, all senior faculty. With the permission of the seniors, we call the session a close, and then we'll meet up for the next week. Portal hypertension case is confirmed. Other case I will shortly inform. So next week will be portal hypertension. Thank you very much, Arya. Give my kind regards to SP sir as well as Rahul sir for kindly permitting you to be here with us.
Sure,
Thank you very much. Good luck to you.
Sir.
All the best, ma. Thank you.
Thank you, sir. Thank you so much.
Thank you, sir. General, sir.
Thank you.
Thanks, sir.